So John, I have two questions for you. First is, what is the state of testing for the coronavirus right now across the African continent? How much capacity is there? How confident are you that a good chunk of cases are getting identified? And then the second follow-on question, and this is very difficult for anybody, but I'm going to ask you as one of the true experts. You told us you are a virologist, so even the area is within your area of expertise. How do you see this playing out over the upcoming weeks and months in terms of coronavirus across the African continent? But if we could begin with testing first.
Yes, absolutely. I think testing, we are at a better place than we were 1 month ago. That we should recognize that and celebrate that, because as I said, in January and December we had 0 reagents for testing in Africa, and today over 42 countries have testing capacity at the central level. We also have a stockpile of about 60,000 tests. Just this morning when I woke up, and the head of the disease control program in Cameroon called me and said, we have a confirmed case, but we only have 100 tests at the Pasteur Institute. I said, relax. The next tomorrow, you get 1,000 tests to support you. Relax, we're sending you 4 more people to train you on prevention, on infection prevention, control, and contact tracing, because this individual is a French guy who came in and attended a funeral, mixed a lot, and so I think our strategy for the continent has been ability to rapidly detect and rapidly to contain. So what you're hearing from me is we've scaled up diagnostics, at least at the central level. I want to underline that from almost 0 countries in January to more than 42 countries there. We've created networks where countries that we do not have will be supported by other countries there. We have a stockpile of those tests there. 60,000 may not be enough, but it's a good start. And we know now the relationship. We've set up a supply chain management system with a group in Germany. So our greatest need now for the continent is to cascade the testing within a country down, okay, and make sure that the diagnostics now leave the central labs, and because you really don't know where the outbursts will occur on the continent. I think that addresses that question. Very early on, we established what we call the African Task Force for Coronavirus Preparedness and Response, which is, the principle of that is that we need to coordinate our efforts, collaborate and communicate. And that, secondly, that we have to rely on all the capacity that exists on the continent. Take out your flags, like Africa CDC or WHO or whatever, and just be Africans and solve the problem. So that we have 6 working groups there. One is laboratory, infection control and prevention, risk communication, care and treatment, and enhanced surveillance. All of these groups are co-led by people in the country. Okay, from the lab is co-led by Amadou Sall in Senegal, the director of Pasteur Institute. That's how we said to him, Amadou, our role is to call the member states, bring them together, pay their tickets, channel them to you, send you the reagents, you organize the training. We'll come support you, find the faculty, and we support you. We do that. Chikwe in Nigeria heads the infection control and prevention. He's the head of the National Center for Disease Control in Nigeria, the Nigeria version of that. So by taking ownership and leadership back to the continent and recognizing that expertise doesn't need to sit within Africa CDC, but it's a continental agenda, is the principle of our task force that it operates there. With respect to the question of what will happen in the future, there are 3 scenarios that are going on now, as we speak. One is people have slipped in with symptoms and without symptoms, and we didn't know, and they are seeding the infections everywhere, and then we'll see an outburst. So that is a scenario that wakes me up at night. Second scenario is we and this is the best case scenario, that the cases that we have picked are really the only cases that have come to the country. I really doubt that. That is what that
it's
is.
Very optimistic.
It's very optimistic. That, I mean, our early dictation and is that, I mean, the third scenario is that we miss some, and that that we detected some of these individuals, and we will not be able to find all the contacts from these individuals, and then they will seep the infection into the community. 2 of the 3 scenarios may actually be in play now. So to respond to that, what we've done is to set up a network of testing, okay, active testing. Now, since we have tests now, what we're going to do is to set up an ILI, that is influenza, like illnesses and networks around. And by next week, this same group of people that I discussed, that is we call it AFCOT, the African Task Force for both the lab and surveillance group are coming together. We have a conference call with the selected countries that will be testing actively, including at public health health facilities, or the big hospitals in cities, and just actively testing for that with people who come show with symptoms and whatever. That will begin to address the question of, because if they are sick, they'll go to the hospital, right? They will not be home. They will mean people will directly go to the hospital, and then when they go to the hospital, they infect healthcare workers there. So we'll see. In the next 2 weeks, email me that question, or 3 weeks, email me that question. We'll see if we are missing out things on the continent or on a bit. As for now, we can only say that the initial investment that we put in terms of arming the countries to dictate is paying, because without that, you will still just be in the dark.
Yeah, it's really it is the cornerstone of basic public health that you are implementing, but it's actually very hard to get it implemented across the whole
Very
continent.
hard, yeah.
But it's fundamental. There's no solution around it. I just want to say again, thank you very much.